Hello and welcome everyone. So today let's learn about bleeding in early pregnancy. So let's quickly start. So let's start by understanding the cause of early pregnancy bleeding. So bleeding in early pregnancy can be broadly divided into two main categories. Those are pregnancy related cause and the other one is associated condition. So as a healthcare worker, we need to understand or identify what is the actual cause so that we can manage it accordingly. So let's start by what is understanding pregnancy related cause. So this condition are directly linked to pregnant state, okay, uh, which means because of the pregnancy there is a bleeding and induce spontaneous abortion consists of 95% of the cases, ectopic pregnancy, hydatiform mole and implantation bleeding. All these condition leads to bleeding. So as a healthcare worker, we should also understand that all these condition also requires an immediate medical attention. So here if you see the bleeding has occurred because of pregnancy. Okay, so now let's learn about the associated pregnancy. So these are pre-existing or pregnancy aggravated condition unrelated to pregnancy itself. It is not because of the pregnancy, but because of pregnancy it has got aggravated. Okay, now the condition was already there, but because of the pregnancy it has aggravated. Okay, so what all condition can it be? Those can be cervical lesions such as vascular ectopy, polyps, ruptured varicose vein and malignancy. So now let's learn about spontaneous abortion. What is spontaneous abortion? According to WHO, abortion is defined as the expulsion or extraction of embryo or fetus weighing 500 gram or less when it is not capable of independent survival, which is if it gets delivered, it is not capable of independent survival. The weight corresponds to approximately 22 weeks of gestation, and the term miscarriage is the recommended terminology for spontaneous abortion. So let's see what are the statistics. 10 to 20% of all the clinical pregnancy ends in miscarriage. 75% of the miscarriage occurs before 16 weeks, and 80% of early miscarriage happens before 12 weeks. Another 10% or 10% are induced or deliberate, which is medical termination of pregnancy. Okay. So now let's see the major cause of miscarriage. Okay, so there are six causes. The first one is the genetic factor. The chromosomal abnormalities are the leading cause of early miscarriage, which consists of 50%, with autosomal trisomy, especially trisomy 16. Okay, and monosomy X consists of 20%. The other cause is anatomical abnormalities. Anatomical abnormalities such as cervical incompetence, uterine malformation, fibroid, and adhesion can interfere with the implantation and fetal growth. Okay. Number three is due to immunological disorder. So in immunological disorder, primarily antiphospholipid antibody syndrome causes pregnancy loss by affecting trophoblast function and leading to thrombosis. Okay. Number four, it is endocrine factor. Endocrine factors includes luteal phase defect, thyroid issue, and poorly controlled diabetes, impacting implantation and placentation. Number five, the cause can also be because of infection. So placental fetal infection is 5%. From viruses, it is from viruses, parasites and bacteria. Okay, so viruses such as rubella, parasites such as toxoplasma, and bacteria such as chlamydia. Okay, this can also cause miscarriage. So the sixth one is due to thrombophilia. So inherited thrombophilias such as factor 5 Leiden mutation cause early and late miscarriage through intravenous coagulation and thrombosis. There are other factors also that leads to miscarriage. The first one is the environmental factor. Um, um, cigarette smoking, which can be active smoking also, or a passive smoker also. Okay, so this also increases the risk of miscarriage. Alcohol consumption also increases the risk of miscarriage. Okay, so and then X-ray radiation, use of anti-neoplastic drugs, anesthetic gases, and exposure to chemicals like arsenic, leads, and formaldehyde increases miscarriage risks. So the other one is the maternal medical illnesses. A mother with the cyanotic heart diseases and hemoglobinopathies are at the risk of miscarriage. Okay, so premature rupture of membrane is inevitable, leads to abortion, and the maternal age is also the significant risk factor for miscarriage. The other third one is unexplained cause. Okay, so despite numerous identified factor, the exact cause remains unclear in the majority of the cases. So about 22% of all the pregnancy detected by the urine HCG are lost before clinical diagnosis. So often more than one factor is present simultaneously. So now let's learn about the types of miscarriage. So we have five types of miscarriage. The first one is the threatened miscarriage. Okay, here the vaginal bleeding has a light brown or a bright red bleeding with mild backache and dull lower abdominal pain. Okay, the cervix remain closed here, and the baby, if ultrasound is done, it shows the heartbeat. The baby's heartbeat is shown. Okay, so in threatened miscarriage, the pregnancy often continues. 98% of the time it continues. Okay, inevitable miscarriage number two, which is there is a heavy vaginal bleeding and heavy vaginal bleeding with severe or colicky lower abdominal pain. Okay, here the cervix is open and the pregnancy cannot be sustained. It is inevitable, the pregnancy will not continue. Here complete miscarriage, all the pregnancy tissues has been expelled. Okay, the fetus and the tissues are all expelled. The pain and bleeding ceases, there is no pain and bleeding, and the uterus feels smaller and the cervix is closed here. Okay, when you do an ultrasound, it confirms that the uterus is empty. Okay, so it is a complete miscarriage. Number four, it is the incomplete miscarriage. Here some pregnancy tissue remains in the uterus. Okay, not all of them is being expelled. Some pregnancy tissues is remains in the uterus, leading to continued pain and bleeding. The cervix remain open and the ultrasound shows a retained tissue. Okay, and missed miscarriage, the baby has passed, it means it has expelled, but the tissue has been remaining. See here in incompetent miscarriage, here also there is a pregnancy tissue remaining. Here also the tissue is remaining. The symptoms include brownish discharge, loss of pregnancy symptoms. Here the symptoms is lost, whereas you have a pain is continued here in incomplete miscarriage. Okay, and the cervix is closed here, but whereas cervix in incompetent miscarriage is open. Okay, and the ultrasound also shows no heartbeat. Okay, in missed miscarriage. So now let's learn about the management of threatened miscarriage. So the first initial assessment is there has to be an investigation which should include blood test for the hemoglobin, hematocrites, ABO and RH grouping. There also has to be a transvaginal ultrasonography so that to assess the fetal viability. Okay, and then serum progesterone should also be checked so that to understand if the value is either 25 ng per ml or more, because it indicates indicates the viable pregnancy. Okay, if it is more or at least 25, that means the pregnancy will continue. Okay, at 95% of the cases, of 95% of the cases. Okay, and then a serum HCG level helps assess the fetal well-being, and here ectopic pregnancy must be ruled out. So the treatment approach is rest, bed rest for few days until bleeding stops. Prolonged activity or restriction has no therapeutical value. Medication and diazepam 5 mg twice daily for if there is a pain relief, if there is a pain, and progesterone treatment may improve the outcome through immunomodulation, okay, shifting from Th1 to Th2 response. Discharge advice: limit activities for at least 2 weeks, avoid heavy work and coitus, and follow up of sonography at 3 to 4 weeks. So let's see what are the prognosis. In an isolated spontaneous threatened miscarriage, about 2/3 of pregnancy continues beyond 28 weeks of gestation, which is a good indication or prognosis indication. The remainder termination as inevitable or missed miscarriage happens. Okay, so 1/3 becomes the either inevitable or missed miscarriage. So the pregnancy that continues has an increased frequency of preterm labor 1, placenta previa, intrauterine growth restriction, and fetal anomalies. So now let's see the management of inevitable and incomplete miscarriage. Okay, so the general measures should be control excessive bleeding with methergine, which is a uterotonic drugs, 0.2 mg if the cervix is dilated and uterus less than 12 weeks. Okay, so correct blood loss with intravenous fluid therapy and blood transfusion. Maintain strict asepsis throughout. If it is the pregnancy before, if the pregnancy is before 12 weeks, then dilatation and evacuation followed by curettage using analgesic or general anesthesia. Alternatively, suction and evacuation followed by curettage can also be done. Okay, so medical management with misoprostol 200 microgram vaginally every 4 hourly is also an option with fewer complication. If it is after 12 weeks, then accelerate the uterine contraction by giving oxytocin drips. Okay, so how much it should be given 10 units in 500 ml, and it should be rapid, 40 to 60 drops per minute. If the fetus is expelled, the placenta is retained. So remove with ovum forceps if separated, or perform digital separation under general anesthesia. And if it is Rh negative mother, then protect the Rh negative patient without antibodies with anti-D gamma globulin. So you need to give 50 microgram of anti-D gamma globulin. If it is early miscarriage, or if it is late miscarriage, then you need to give 100 microgram. Okay, and it should be given IM within 72 hours. And may not be required to a complete miscarriage before 12 weeks without instrumentation. Lastly, the management of missed miscarriage. So the treatment approach depends on gestational age and patient preferences. And there are multiple options available for the safe and effective management. So first is uterus less than 12 weeks. The expected management is monitor for spontaneous expulsion. Okay, so the other one is medical management, where you give a misoprostol of 800 microgram vaginally, can induce the expulsion within 48 hours. It can be repeated if needed. The other management is a surgical management, where you do a suction evacuation or dilatation and evacuation, okay, for definitive treatment if the sometimes if the medical management fails. The other one is the uterus more than 12 weeks. So here you give a prostaglandin induction. That means use of misoprostol vaginally every 4 hourly. Maximum of 5 dose is effective for induction. The other one is oxytocin induction, which is administration of 10 to 20 units in units of oxytocin in 500 ml of NS at 30 drops per minute. Okay. The other one is surgical completion, which is often required post medical treatment to ensure an empty uterine cavity. So ultrasonography guides retained products of the conception. Thank you so much. If you like it, please do share with your friends and your colleagues. Do like and share and subscribe. Thank you everyone. See you in the next video. Bye bye.